Record. Yeah, so it's a pleasure to welcome all of you guys here for this lecture. I'm very excited to have Kimal Honor Djam, who is a physicist who I've known for a couple years now, present on sort of how to manage gaps in radiation therapy care due to a variety of reasons. So yeah, we're very excited to hear what he has to say. And without further ado, I turn it over to Anna.
Hello, everybody. First of all, thank you for tuning in this morning. I believe that this topic is a very, very relevant topic, and it is totally my pleasure to get a conversation going on how to manage unplanned treatment interruptions in radiation therapy. Um, we all know that about 4 to 6 in 10 patients, which is approximately 4 to 60% with cancer, essentially require radiotherapy as part of their treatment regimen. Conventionally, fractionated radiation therapy, for the most part, is often delivered in, between 1.8 to about 2 gray in a single fractions per day, 5 times a week, in about 5 to 6 weeks. And this typically takes into account, the standard working practice with, weekend breaks. Unfortunately, as we all know, unintended treatment interruptions typically occur during, the course of radiation therapy, which can, in most cases, lead to an extended overall treatment time, which in turn, we're going to talk about this in more detail later on, will allow for increased tumor repopulation to occur. Now, one of the common ways to deal with this is really to give an extra dose, which may be required, to offset any loss of tumor control. However, the caution I want to say here is that the manner in which the extra dose is delivered requires really careful consideration in order to avoid the risks of increased normal tissue toxicity. And so the agenda for today is pretty straightforward. I will briefly discuss the importance, of radiation therapy in relation to TCP and TCP. In other words, I'll talk about it in terms of, tumor control probabilities and normal tissue complication probabilities. Then we will look at how unscheduled gaps in radiation therapy affect local tumor control. We will discuss evidence from clinical studies, as well as long as time permits, we will categorize the different cancer patients based on the rate of tumor repopulation. Now, this is really important as really a proposed way of dealing with gaps, because it really depends on the particular cohort of patients as well as the particular cancer type. Different cancers grow at different rates and behave differently with different radiobiological characteristics. Now we will take a deep dive on the radiobiology of unscheduled gaps in radiation therapy. I will specifically focus on the LQ model, which in turn will be the basis that will help also calculating the changes in the dose per fraction and the other variables that are important when dealing with extended gaps in radiation therapy. Now, at the end of this presentation, I have a few discussion questions that we will consider, some of which include things like, does the length of the unplanned gap matter? Does the position or timing of the unplanned interruption matter? Now, we will look at this based on published current publications and practices going on in the field of radiation oncology. And lastly, which is the most important part, I'm going to suggest practical steps on how to manage unplanned treatment interruptions in radiation therapy. Now, I've categorized this into 2 categories. You have preventative measures, you have compensatory measures, and how all of this can be practically implemented in the clinic. Now, in the course of the presentation, I don't know, Joe, how you want to handle this. Are we going to wait and answer questions at the end, or are we going to talk about the questions as, we discuss the concepts?
Yeah, usually we wait till the end for questions, but it's as you like for sure.
Okay, perfect. I may not be able to see the chat while I'm presenting, so if somebody has a question, you just ping me and let us see if we can talk about it, or we could just wait to the end. And so the question remains, one, keep in mind that one of the main principles of radiation therapy really is to deliver the total fractionated dose without interruption and without a prolongation of the overall treatment time. Now, the prolongation of treatment time caused by unexpected interruption is known, has been demonstrated to affect, local control when there is significant repopulation of tumor cells. But however, in clinical practice, especially in developing countries where there are a variety of factors that comes into play, which, and I'm not going to deal so much into this socioeconomic factors. We typically, experience unplanned treatment interruptions, and this broadly can be categorized into two groups. You have interruptions that are independent of the patient, such as public holidays, machine breakdowns, extended service time, transportation problems, equipment breakdown, as well as interruptions that are due to the patient. The patient may just be too ill or unable to have the means to transport his or herself or place to stay during the course of radiation therapy. And all of these factors can lead to an unplanned gap in treatment interruptions. Now, the first part of this presentation, we'll look at the relevant radiobiology of unscheduled gaps in radiation therapy. Now, what we need to keep in mind is that, local tumor control essentially is the main objective for curative radiation therapy. Which means that improvements in local control after radiation therapy has been shown in many clinical trials to translate into, prolonged survival of cancer patients. The implication of that statement is that local control or local tumor control is conceptually the preferable endpoint for radiation therapy. Now, a tumor is locally controlled when all its clonogenic cells, in other words, that is, all the cells really have lost the capacity to proliferate and to cause reoccurrence after radiation therapy have been inactivated. Now, the probability of achieving local control is proportional to the radiation dose delivered. In other words, it is totally dependent on the amount of dose delivered. Now, each fraction during the course of fractionated radiation therapy essentially reduces the total population of clonogenic tumor cells within a tumor, which in turn causes a depopulation of the clonogenic, tumor cell compartment. And so in general, clonogenic cells that survive radiation can repopulate the tumor by, either proliferation or a dramatic reduction in the cell loss factor. Now, if a tumor still has the capacity to repopulate, any prolongation of the overall treatment time essentially results in a higher number of clonogenic tumor cells, which need to be inactivated and therefore requires a higher radiation dose to achieve, complete local control. And so essentially, the main aim of radiation therapy. Therefore, if you look at, the therapeutic window is essentially to increase the dose to the tumor. In other words, increase the tumor control probability, as well as reduce the complication or the dose to normal tissue. In other words, decrease the normal tissue complication probabilities. And therefore, the amount of dose that can be given or escalated is essentially limited by the dose constraints of the surrounding normal tissue. Okay, now, this graph here is very important, and how it really, I think, as a physicist, it is essential for us to understand how a tumor behaves from the start of treatment to the end of treatment, because understanding the mechanism, the radiobiological parameters that are important for tumor dynamics in the course of treatment really will inform us about the decisions that we make in the course of treatment. And so the kinetics, that being said, the kinetics and the radiobiological mechanisms of tumor repopulations essentially have been studied in an extensive series of experiments with fractionated irradiation given to human tumor xenografts. Now, these xenografts were either studied under, clamp hypoxia or under normal blood flow conditions. This is very important. Now, as you can notice in this graph, let me choose my laser pointer. Now, as you can notice in this graph, the x-axis is in weeks, the y-axis is TCD tumor control dose 50. Now, what you need to keep in mind is that if you look at this graph, around 3 weeks, there is a switch to rapid repopulation, which essentially implies that there is, when we start treatment, there is essentially a lag period where there is little or very little or no growth. Now, on and around 3 weeks consecutively in several studies, they found out that the tumor starts to rapidly repopulate itself. Now, the note I want to keep here is this, is that the rate of cell division essentially varies widely among similar tumors and different tumor types. What this implies is that the longer a course of treatment, the more stem cells can repopulate, which in turn increases the number of stem cells that needs to be, inactivated. As a result, any increase in the overall treatment time therefore decreases the probability of local control. And if you think about different tumors grow differently. For example, prostate grow very slowly, head and neck cancer grow very rapidly. Non-small cell lung cancer is another rapid growing tumor. And therefore, the rate of repopulation of these tumors we need to really be considered very, very carefully. Now, the previous study was done in human xenograft implanted into, immunocompromised rats. And some people will say, well, we know animals essentially behave differently than humans, but what about humans? Now, in an extensive clinical review of published data, which is shown by this graph, which was actually conducted. This is a very popular paper that was published way back in 1988 by Witter's group. Now, what they found out is that tumor cell repopulation essentially was derived from analyzing, looking at the treatment times for head and neck patients. And what they found out that the analysis essentially revealed that maintaining ISO effectivity necessitates an increase in the tumor, necessitate an increase in the total dose if the overall treatment time is extended. Now, if you look at, this is essentially from day 0 to about 30 days, there is a rapid switch to, rapid growth of head and neck cancer cells. Now, the slope of this graph, if we do the calculation, is about 0.6 gray. Now, what does that mean? That means that for every 2 gray daily fraction, there is a counterbalance. In other words, every 2 gray daily fraction is counterbalanced by a loss of 0.6 gray due to repopulation, which in turn reduces the effective dose from 2 gray per fraction to a dose of 1.4 gray per fraction. Essentially, the effectiveness of this particular treatment regimen, therefore, is drastically affected if we do not take into account this rapid repopulation. And so what then is the clinical relevance? In other words, the substantial impact of repopulation on effective dose essentially underscores the importance of meticulous treatment time and dose planning in order to achieve optimal local control of tumors, especially in sensitive tumors like head and neck, or sensitive areas like head and neck. Now, when we think about conventional radiation therapy, which typically is delivered or administered over between, 5 to 7 weeks, this is a pretty long time, which allows for significant cell repopulation or proliferation in both tumors and the surrounding critical structures. And so in order for us to deal with this, I think that it is essential to look at this from 3 categories. You have early reactions, you have late reactions, and we need to talk about the tumors. Now, typically normal tissues, that early reaction tissues are typically normal tissue that responds early and often, repopulate rapidly. What this means is that their resistance to radiation is partly due to the extensive repopulation over weeks. Now, in this particular instance, as actually demonstrated by Fanwick's group in 2006 in a published paper, by essentially reducing the treatment duration means that we have less time for repopulation, which can actually lead to early severe reactions. Now, if we want to think about late reactions, which typically are involved, the cells involved in late reactions typically proliferate very, very slowly. And therefore, the impact of this is that modest alterations in the treatment times essentially have a lesser impact on late reaction. In other words, there is no significant dose adjustment required for any minor changes in the treatment durations. Now, this in turn is a little bit different when we're dealing with tumor cells, because one, the repopulation rate really in tumors is really, really diverse depending on the particular tumor. Now, while I would say here that many human tumors have been observed to grow slowly. In other words, the average volume doubling time for many human tumors is around 3 months. And what that means is that there is a significant boost in repopulation when the tumor shrinks. Now, from the previous graph, repopulation doubling times is typically under about 7 days. What this implies is that treatment time, depending on the repopulation time for that particular tumor, therefore is very pivotal if we want to invoke and enhance local tumor control. And so to explain this graph, which is popularly known as the dogleg curve, if you look at this graph, I'm going to divide this graph into 3. You have the initial period, This is the onset of repopulation, and this is rapid repopulation. Now, why do tumors generally behave in this way? Essentially, if you think about this, at the start of radiation therapy, numerous tumor cells are notably distanced from, blood vessels or blood capillaries, to be more precise, and each essentially, because of the poor vasculature of tumors, especially bulky tumors, experience a varying degree or different states of hypoxia. What that essentially implies is that the tumor cells are predominantly quiescent or multiplying at rates significantly slower than the initial creation rate. And therefore, the high cell loss factor, CLF, which is characteristic, which is a term that is used to describe the rate at which a cell replicates, is essentially stable or a little bit small. But what happens at around this T delay or at the onset of repopulation? When we begin radiation therapy, the tumor begins to diminish in size. The important thing that happens when the size of the tumor begins to diminish is that it leads to improved vascularity, which in turn leads to a corresponding reduction in the cell loss factor. Now, what this implies is that non-sterilized cells begin to experience enhanced oxygenation. Once they begin to experience enhanced oxygenation, it leads to an acceleration in their growth or repopulation, which essentially is defined by what we call the potential doubling time, T-part. And so between 0 and about week 3, demonstrated on this graph, this is for this particular graph, it's different for every tumor. The tumor size essentially diminishes or reduces, which means that those hypoxic cells that were deep within the core of the tumor will now become reoxygenated. And so at about T-part, they start to repopulate because they now have an enhanced oxygenation coming in, because the cells like peels off, or the tumor peels off like the skin of an onion. Now, the thing I want to note here is more aggressive tumors typically have very small T-part values, which often are under 7 days, does reflect an elevated rate of tumor repopulation during treatment. And so the question I want you to begin to think about is, if we have a treatment gap within the first lag period and a treatment gap, after the onset of rapid repopulation, what would be the dosimetric implication to that particular patient? Now, I'm going to answer this question towards the end of this presentation, but it's something that I feel you should begin to think about as we have this ongoing conversation. And so to summate this slide, there is, a paradox where the extent where the extinct tumor cells towards the end of treatment. Remember that tumor cells towards the end of treatment are often experiencing their maximal growth rate. What this means is that any extension in treatment duration will inadvertently allow for more tumor cells to be created mitotically. And therefore, the lack of any additional dosage during this extended period implies that the eradication of these newly formed cells becomes difficult, and therefore it could lead to a compromised tumor control. And it's something that I feel is very important for us to kind of think about. And so there are just a few couple remarks that I want to make before we proceed here. Now, the lag period, like I said before, refers to the duration it takes for repopulation to commence in both early responding tissues and in tumor after the initiation of radiation therapy. Two, the duration of lag period, is tumor dependent and rarely is precisely determined. Keep that in mind. Really, I've looked through data and there is no data that precisely say that this particular tumor has this particular lag tumor. So the data is still very sparingly available. However, evidence suggests that in both normal tissues and tumors, lag periods may span approximately 2 to 3 weeks. Now, the next thing that you should keep in mind is the fact that wide variability exists in the rate of cell divisions among similar tumors and across different tumor types. And so if we extend, or in other words, this implies that extended treatment allows for an increased opportunity for stem cells to reproduce and thereby increasing the quantity of stem cells that needs to be obligated. Now, I think at this particular point, it's essential for us to look at how the 5 hours of radiobiology influence the treatment gap, because it really helps us to kind of understand the dynamics of what's going on when we start treatment until the end of treatment. Now, the 4 or the 5 hours of radiation biology, depending on your philosophical stance, signify the critical factors influencing the effectiveness of radiation therapy in tumor cell killing. Now, conceptually, when we are looking at the sequence of events, we have to think about, the repair, redistribution, reoxygenation, radiosensitivity, and repopulation during the course of radiation therapy. Now, when you think about repair, the repair of, cell repair or tumor repair typically begins immediately post-irradiation and can extend up to hours. Now, and we know that this repair essentially refers to both lethal and sublethal damage that occurs. Now, sublethal damage typically undergoes repair processes almost immediately post-irradiation and continues over hours or even days, depending on the extent of damage. Now, once this process is initiated, what happens is that the different cells within the targeted area will then progress at varying rates throughout the cell cycle. The implication is that this alters the radiosensitivity of the cells to radiation. And so the redistribution of cells in various phases of the cell cycles in turn modifies the radiosensitivity. In other words, it's observed within hours to days post-irradiation. Now, as the treatment progresses, the initial hypoxic cells that are typically found within the core of the tumor gain access to better oxygen supply, leading to reoxygenation over days, which in turn decreases the radioresistance. Now, the inherent radiosensitivity of a tumor, which in turn depends on the tumor type, in turn impacts the effectiveness of the treatment throughout the entire course of radiation. Now, the most important factor in regards to this conversation is that tumor cells, as well as specific normal cells, typically start repopulating soon after the initiation of radiation therapy and usually continue doing this during as well as between every fraction. And this can actually sometimes commence after and also keep in mind that the rate of tumor growth is steady, slow during the lag phase, and after the onset of rapid repopulation, it kind of actually triples. And so we have to keep that into mind as well. And so the implication is that we need a comprehensive understanding, of these interconnected events and their timelines in order for us to produce or optimize, our treatment regimens for a particular patient in the course of radiation therapy. And so the approach that I'm going to use in our gap calculation will be based on the linear quadratic approach to fractionation. Now, when we talk about the linear quadratic approach to fractionation, there are some key important concepts that comes to mind. One, the biological effective dose, or E, which essentially is a measure of the effect of irradiation and mathematically represents the logarithmic cell kill because of radiations. Now, let's suppose that we have n fractions. Each of those D. Now, full repair of all sublethal lesions in the interval, between consecutive fractions, which should be a minimum of about 6 hours, implies that the surviving fraction after n fractions will be given by the very first equation, equation 1. Now, the quantity inside this bracket is what we call the biological effective dose, which is essentially equal to D multiplied by the relative effectiveness. Now, the biological effective dose values indicates how much damage a particular fractionated regimen will do. In other words, it is the total dose given in an infinitely small fraction that will have the same radiobiological effect as the actual fractionated regimen with a fraction size D and a total dose D. And it is important to think about the biological effective dose as the total dose multiplied by the relative effectiveness. And so to summate this, BED is the primary measure of radiation effect. And in conventional fractionated external beam radiation therapy, depends on one, the dose, the total dose, the dose per fraction, as well the number of fractions, as well as the overall treatment time. Now, on the other side, if you look at the Witter's ISO effect formula, now if we consider hypothetically, an ISO effect calculation where we want to know for a given tissue and a change in the dose per fraction by how much the total dose should be adjusted. Now, it is inherent here to assume that the reference schedule has a total dose, let's call it D reference, and the dose per fraction DREF. This is the initial reference dose. Now we want to calculate by how much the dose per fraction will change to have the same, biological effect. Now we need to assume that one, the essential thing is that the BED between the new and the old stays the same. So if we equate the two, it gives us equation 5. Now, equation 5 here is very important in that it gives us what we call the ISO effect relationship, where we could actually compare one fractionation scheme to a new fractionation scheme to give us the same biological effect, assuming that there is no, overall extended time. if everything works as initially planned. Now, when we look at what does this actually imply, this is really summated. The two graphs here shows two different fractionation scheme. You have here a hyperfractionation of three fractions in 1.1 in 11.1 grades. This is 20 fractions. The standard fraction in 2.75 grades. Now, let's look at the overall effect that occurs for tumors with an alpha-beta ratio of 10, and for normal tissues with an alpha-beta ratio assumed to be 3 in this particular case. And so the linear quadratic model essentially describes two components to cell kill by irradiation. Keep in mind that the surviving fraction, S, is the fraction of cells surviving a dose D, and alpha is a constant that describes the initial slope of the cell survival curve, while beta is also a radiobiological constant describing the quadratic component of cell kill. And so in general, alpha and beta are therefore the linear and quadratic radiosensitivity coefficient that characterizes, the linear quadratic model, which in turn depends on both the cell type and the cell environment. And so the linear term is famously known to be associated with, lethally misrepaired double-strand breaks or unrepairable DNA damage formed by a single radiation track, whereas the quadratic term is attributed to two double-strand breaks formed by two independent radiation tracks traversing through the cells, perhaps at two different times. Now, this is important. When the alpha-beta ratio is large, this implies that the linear term predominates. And so the slope of the log of the survival fraction against the dose curve will relatively be straight. This is the case with cells with little repair capabilities, such as cancer cells. In other words, cancer cells predominantly have a larger alpha-beta ratio. On the other hand, when the alpha-beta ratio is small, this essentially implies that there is a more likelihood of double hit required for a lethal event to occur, which in turn implies that the curved part of the plot, predominates. In other words, the plot becomes more curved. And so normal tissues essentially typically have a much more smaller alpha-beta ratios. And so in essence, in doing our gap calculations, therefore, we need to keep in mind that the alpha-beta values, one, are tissue specifics, and is the ratio between the linear and the quadratic radiosensitivity coefficient, which characterizes the linear quadratic model. And therefore, the alpha-beta ratio is an inverse measure of the fractionation sensitivity of a given tissue or a given organ, and determines the dependence of outcome on the dose per fraction, and therefore it's essentially very important quantity in distinguishing, the effects of either you're looking at SBRT or conventional radiation therapy. Now, late responding normal tissues, which usually sets the limit on how much dose can be delivered in any radiation scheme, are generally more fractionation sensitive than normal tissues. As a result, they possess lower alpha-beta values than tumors. If we have to keep that in mind. So if we look at this particular graph here, you can clearly see that the hypofractionated regimen of 3 in 11.1 gray per fraction is significantly more toxic. In other words, it has a lower final, if we plot a graph for a particular dose upwards, you will realize that it has a lower final surviving fraction compared with the other fractionation scheme. And so what does this mean? This essentially implies that to achieve a normal tissue isoeffectivity with an alpha beta ratio of 3, the dose delivered in the 3 fraction would have to be reduced from 11.1 gray to about 8.9 gray, and which implies that if we do this, it in turn decreases the effectiveness of the prescribed dose. So we have to think about these things very carefully. And so to mathematically derive the gap calculations, to actually formalize this, when you look at the log curve, the dogleg curve for tumor response, generally you have the lag period, which is a period of little or no tumor repopulation. And then you have here the onset of rapid repopulation defined by what we call the delay time. And after which you have rapid repopulation. This is a period of steady repopulation. Now, the slope of this graph defined by a constant called K really is tumor dependent. Is totally tumor dependent. Now, for any treatment time greater than T delay, greater than this time here, the iso effect dose must be increased to compensate for the subsequent tumor repopulation if we are to actually keep the effectiveness of our prescribed dose. What then does this imply? This means that we need to modify, if we go back here, this is our surviving fraction curve, which assumes that everything goes as planned without taking into consideration, repopulation because of extended treatment times. But if we extend the overall treatment time by T, then we need to modify our equations to be able to compensate for this increase in time. In other words, to maintain the tumor iso effect would therefore require the addition of extra dose, which incurs an added penalty, or in other words, because of the fact that the therapeutic index is constant in terms of a higher normal tissue dose. Now, to prevent overdosing of the normal tissue would require that the supplemental tumor dose needs to be reduced in order to limit the detrimental effect. And to do so, the surviving fraction curve becomes this equation right here. Now, when you look at this equation, there are key differences that I want to emphasize here. This section is added to take care of the extra cells that are created because of rapid repopulation. There are a couple of constants that I want to define, the constants K. The constants K, if you solve for the constants K, it is equal to the natural log of 2 divided by alpha over T half. And here, keep in mind that T is greater than T delay. So we're talking about the zone after the onset of rapid repopulation. Now, to prevent miscalculations, remember in science, we can only add or subtract 2 or more physical quantities that are dimensionally the same. So we cannot add torque to work. Even though they have the same units, Newton meter, they are not dimensionally equivalent. This is important here as well. K is expressed in gray per day and is a property that refers to as the daily BED equivalent of repopulation, which is required to sterilize the new cells created, following the onset of significant repopulation. And so K is essentially related to the rising slope. On the other hand, K multiplied by T minus T delay is the BET equivalent of the total repopulation occurring in the added time interval. And so if you keep that in mind, then if you remember that the biological effective dose is just the natural log of the surviving fraction divided by alpha, if we solve for that equation, then the effective biological effective dose, taking into account tumor clonogen proliferation after the onset of rapid repopulation, becomes this equation. Now, this equation might look a little complicated, but it is easy to actually remember this equation if you break it down into two components. So the total BED, or the effective BED, is equal to the original BED plus the BED of the proliferated clonogenes. And so if you look at this equation, this is what we knew. This is the addition in order to account for the extra cells. And so, therefore, it is logical to, it is a more logical way to deal with the effect of clonogenic proliferation during fractionated treatment, to kind of rewrite that big equation in terms of the original BED plus the BED proliferation. Now, T in this particular equation is the total duration of the fractionated treatment course. T delay is the time after the start of the first fraction when the clonogenic proliferation assumes to start. It is typically about 21 days or between 21 and 28 days on average, but it changes from tumor to tumor. So when you're doing your calculations, you have to make sure you put in the right values. If you put in garbage in, you get garbage out. You need to keep that in mind. Now, this expression here, T minus T delay, all divided by T proliferation, TP is the number of doublings. And therefore, this equation expresses the fact that the overall BED has to be increased by BED plurif to compensate for, the rapid repopulation. In other words, to achieve the same effect on the tumor in practice, to achieve the same effect, in other words, to maintain the same tumor control probability, we have to take into account this particular section. Now, to break it down, more simply for you to kind of look about it, on the right side of the graph, we have the BED for late responding normal tissues. It's the same as the initial BED. Now, here's my rationale for simplifying this equation this way. The proliferation rate of most late normal responding normal tissue is typically very small. Mathematically, what that means is that the K value can be neglected or assumed to be zero. And if the K value can be neglected or assumed to be zero, it means that we can simplify the BED for late normal to remain the same. The exception here is for spinal cord, which really has an alpha beta ratio of about 2, and it's rapidly proliferating, so you have to keep that in mind. When we think about the tumor, again, for most tumors, I'm assuming an alpha beta ratio of 10. It's not generally the case for all tumors. When you're doing the calculations, you have to use the right alpha beta ratio for that particular tumor. The only caveat is there is no standardized table that gives us the alpha beta ratio for every tumor that exists out there. And so we need, like I said before, think about the original BED plus the BED due to the cells that are exactly growing. Now, to piggyback on something I said before, keep in mind that even though the slope K is expressed in gray, we should not mistake that to be equivalent to physical dose, which is also in gray. K and physical dose are like torque and work. Even though they have the same unit, they are not dimensionally equivalent, so they cannot be added or subtracted. In other words, K is the biological effective dose equivalent of a single day's worth of repopulation. And that is not the same thing as physical dose, so we cannot simply add the two. And it's something that you have to keep in mind as we embark on doing this. Now, also, another caution I want to say here is we have to, when we think about when we're doing our calculations for overall treatment times, we cannot treat it as we do for hyperfractionation and accelerated fractionation. Let me explain. Now, hyperfractionation and accelerated fractionation should not be confused with gap calculation. Now, the context that I'm speaking about, hyperfractionation in this context, implies a reduction in the dose per fraction below the conventional size of 2 gray, while increasing the number of fractions. Now, typically, to achieve the required total dose without extending the overall treatment time, more than one radiation dose per day needs to be given or must be given. In other words, this will be some sort of a BID treatment. Now, the aim of, for the most part, the aim of hyperfractionation is really to explore the greater recovery capacity of late responding tissues compared with normal tumors. Now, when we think about this carefully in radiobiological terms, the iso-effective total dose for late responding normal tissues, which typically have a low alpha beta ratios, changes rapidly with a change in fraction size. If you look at this graph here, and so what that means is that increasing. Now, what that means, can you please mute yourself? Thank you. Now, what that means is that if by increasing the dose per fraction above 2 grays, it typically leads to a slight decrease in the therapeutic index. And so by the same reasoning, there should be a slight gain in the therapeutic index if the dose per fraction is reduced. But if we do this, and we have to maintain the overall treatment time, we then need to increase the number of fractions delivered per day. Now, on the other hand, accelerated fractionation in this context essentially implies a reduction in the overall duration of radiation therapy while using our conventional fraction size. And usually the aim of accelerated fractionation is to reduce the impact of tumor cell proliferation during treatment. Now, as with hyperfractionation to deliver the prescribed dose within a short overall treatment time without increasing the dose per fraction, we must deliver more than one fraction per day. And if we do that, as a medical physicist, one of the jobs that you need to do is to make sure that we take into consideration the radiobiological parameters of that particular tumor. So it has been recommended that for accelerated and hyperfractionation to actually work, it is essential that there is sufficient time between fractions for full repair of sublethal damage to occur. In other words, the rate of repair in late responding normal tissues, keep in mind, tends to be much more slower than in tissues. And so if two fractions are given close together, less repair may have occurred in normal tissues than in tumor, which is essentially a therapeutic disadvantage. And therefore, I recommend that if we want to practice hyper or accelerated fractionation, the dose per fraction should be given at least 6 hours apart to allow for sufficient time, for full repair of sublethal damage in late responding normal tissues. So when you look at the equation here that takes into consideration BID, we have an added expression here. H reflects the increased damage caused by the incomplete repair, which in turn is dependent on what we call the interfraction intervals. And the interfraction interval should be a minimum of at least 6 hours apart. So keep that in mind. Now, here are some suggested values. Like I said, each tumor is different. Alpha, beta, and K are tissue specific, and therefore appropriate values typically must be selected for each when calculating our tumor BEDs. Remember, a low alpha beta ratio between 0.5 and 6 gray is usually characteristics of late responding normal tissues, and a high value is typically characteristics of early responding normal tissues or rapidly proliferating tumor cells. For normal tissues, it is okay to assume an alpha beta ratio of 3 for soft tissue bone, but 2 gray for nervous system organs, including the spinal cord. And so at this particular juncture, when you're doing the gap calculation as a physicist, it is really important to collaborate with your attending physician about the characteristics of each tumor. And this graph here, I actually got this graph from a paper by Dells that gives us some of the proposed values for alpha, beta, and K and T delay for some common tumors that you might encounter in the clinic. Like I said, extra care should be taken to ensure that the BED in normal tissues are not exceeded for hypofractionated treatments as well. And so then this brings us to the question, how do we respond to gaps in treatment? Now, the two most important factors in the radiobiology of gap compensation, like I've discussed really well, are repair and repopulations. And so, gaps can be compensated for, but the larger the gap, and watch this, the nearer it is to the end of treatment, the more difficult it is to be compensated. Now, one of the documents that I love really much that really has some profound recommendations in order to deal with events of treatment gap to minimize the effects of treatment outcome is a document published by the UK Royal College of Radiologists. way back in 2019, which is pretty much very recent. I encourage you to kind of get the document. At the end of this presentation, you can actually contact Joe if you need it, and he will be. I'll send it to him, and he will be able to email it to you at your request. And so, to think about how to deal with gap compensation, I want you to kind of always have these two categories in mind. You have your normal tissue and you have your tumor. Your target is to limit NTCP and to maximize TCP. When you think about late responding normal tissues, the BED is given by this equation on the right. When you think about tumors, the BED is given by this equation on the left. In order to make the process of calculation a lot easier to follow, I have kind of broken this down into 3 sections for every category: normal tissue and tumors. Let's begin first by looking at the normal tissue. 1, you have to divide the period into 3. You have the BED to completion if there was no interruption. We need to calculate that. I will call it the prescribed normal tissue BED. If a gap occurs, then you have to think about the BED to the gap, which I call the pre-gap BED. Then, after the gap has occurred, what is the BED that is required to restore the prescription after the treatment restarts? I call that the post-gap normal tissue BED. The same holds true for tumors. The same holds true for tumors. Now, it should be noted here that the post-gap tumor BED is the minimum BED ideally required for the tumor, while the post-gap normal tissue BED is the maximum remaining biological effective dose allowable for the normal tissue without increasing, the tolerance or the dose tolerance of the tissues. And so to break it down into steps, which really makes it easy, I've kind of broken it down into 6 practical steps that you can follow in order for you to do these calculations. Now, remember that the linear quadratic model utilizes or incorporate, tumor proliferation adjustments, which is based on experimental data. And this model is, is very sensitive or dependent on the different sensitivities of tumors and normal tissues. In other words, it depends on the alpha beta values that we use. And so you have to ensure that you use the right values if you are to get the right results. Now, when you look across literatures and textbooks, just beforehand, there's discrepancies in the estimated alpha beta values, which imply that if we use different sources, we will get different outputs clinically. And therefore, it is really important for you to work with a clinician to be able to get the appropriate values to be calculated. Now, the very first step is to calculate the original prescribed normal tissue BED, what I call initially the prescribed BED. Once we determine that, once the gap occurs, the next step then would be for us to calculate the pre-gap BED. Now, once we calculate the originally prescribed BED and the pre-gap BED, the next step really would be for us to review the treatment options. In other words, we will determine the post-gap BED or the remaining BED to be delivered. And from that value, we can evaluate alternative treatment options like, twice daily fractionation or increased fraction size. If we decide to go with increased fraction size, Then we need to calculate the required dose per fraction in order to achieve the required late normal biological effective dose while minimizing the extension of what treatment time. The key here is our option is always to try to minimize the extended treatment time. And so here is our first example that we will consider. This is a case where the patient disappeared on the third week of treatment for a treatment that was scheduled for 70 gray in 35 fractions over 46 days. And so the original plan for the treatment was 70 gray in 35 fraction over 46 days. And when did the interrupt? Remember, the time of interruption matters. If the interruption occurs closer to the end of treatment, it becomes a little bit challenging. But if it occurs closer to the start of treatment, as in this case, it can be dealt with in a very straightforward manner. And so in this particular case, the interruption occurred all of the 5 fractions in the third week were lost. And so 10 fractions have been delivered, 25 fractions remain to be given. What then is the available time within the prescribed treatment period of 46 days that are remaining? We have 26 remaining days, including weekends, to complete the treatment on the prescribed finishing date. And so there are 2 approaches that we can use here. One, depending on the center, most centers in the US do not treat on the weekends, but most centers abroad in Africa, some centers treat on the weekends. Now, depending on your protocols and your practices in your centers, there are generally 2 approaches that we could handle this particular case. One, we could incorporate weekend treatments, which means that if we utilize 5 of the 6 remaining weekends along with weekdays, and if we do this, in this particular case, we treat on Saturday and Sunday. Remember, there are 5 weekends remaining. We will be able to treat the entire prescribed dose within the prescribed period without a need for a change in fraction size or extension of the overall treatment time. And this is really considered a good option, but it is a lot more taxing because everybody needs to come in during the weekend for a treatment. Now, another alternative that could be considered would be a BID or bi-daily fractionation. Instead of coming in on the weekends to treat, another approach could be that we could deliver 2 fractions on 5 of the remaining 20 remaining days. If we choose to go with the BID options, here are my recommendations. 1, a minimum gap of 6 hours should be allowed, between the twice daily fractions. And 2, spacing the bi-daily treatments on non-consecutively and throughout the remaining schedule actually helps. And 3, we could opt for Fridays for some of the bi-daily treatments to allow more time for tissue repair to occur before next treatment. Now, all in all, keep in mind that we need to consider the fact that when individual fraction sizes are considerably above 2 gray, the spacing and the distribution of the bi-daily fraction needs to be meticulously planned because of the increased concern of normal tissue toxicity. That you need to keep that in mind. And so, in conclusion of this particular example, remember that the objective of the compensation is to adhere as closely as possible to the original plan minimizing deviations in the dose per fraction and the overall treatment time. Secondly, the incorporation of weekend treatments or the implementation of, a bi-daily fractionation essentially seeks to offset the lost time really without altering the radiobiological significance or the local control of the treatment, which is great. And lastly, the spacing of the biweekly fraction, I would say, as well as the days that we choose for this to occur, is very crucial. Is very crucial. We need to give time for full repair to occur in normal tissues compared with tumors, and therefore we have to consider the fraction interval like we did discuss below. The next example is a little bit more challenging. In this particular case, remember the last example, there was a loss, the complete loss of all fractions in the third week, and the third week was still within the lag period. Remember, the first 3 weeks are typically slow and steady. After the third week, for the most part, for most tumors in general, the onset of rapid repopulation kicks in and the cells begin to rapidly repopulate. Now, this period gap occurs after the onset of the rapid kickoff. And so the treatment schedule in this case is still 70 gray in 35 fractions over 46 days. And the gap occurred throughout the entire 7th week, creating a need to extend the treatment schedule beyond the initially prescribed 46 days, which in turn necessitate the use of calculations to determine how much normal tissue BED is still to be given after the gap. In order to do that, if we follow the recipe I gave before, the first step one is to calculate the originally prescribed normal tissue biological effective dose. And if we do that simply, the originally prescribed biological effective dose with an alpha beta ratio of 3 is 116.7 gray. Now, the next step in the process is for us to determine the respective pre-gap normal tissue BED. And we do that, remember, it's still, we're assuming an alpha beta ratio of 3 here. If we calculate that, it gives us 100 gray. Here, now the difference between step 1 and step 2 is what we call the post-gap normal tissue biological effective dose that still needs to be given in order for us to maintain the same original intent of the physician. And this is equivalent to, this is equal to 16.7 gray. And we're using an alpha beta ratio of 3. Remember that this is the amount of BED that is left to give without increasing the NTCP beyond the prescribed dose constraints. And so the next step 3 then would be for us to calculate the tumor BED for the prescribed schedule. Now, in this particular example, for simplicity, I'm going to take K to be 0.9 and our T delay to be 28 days. For the most part, it typically range between 21 and 28 days. Remember, we are talking about a patient that meets the entire 7 week of treatment of 70 gray 35 fractions prescribed over 46 days. And so there are a couple of scenarios that we could think about here. The first scenario is we could think about, adding an 8 week. If we add, for example, if we could add an entire 8 week because 1 week was missing, what you need to keep in mind is that the treatment again, assuming that, the treatment again starts on a Monday, this would imply that the overall treatment time that will be added would be about 7 days. And so let's see what is the consequence of adding 7 days to the end of the treatment. And so to do that, we start first by calculating the tumor BED, and we use our famous equation. I'm taking K here to be 0.9. In other words, what that means is that the tumor is growing at the rate, the consequence of the daily BED is 0.9 gray per day. That is the loss in the BED per day due to repopulation. And so when we do that, we end up with our calculated value of 67.8 gray, assuming that the alpha beta ratio for tumor is 10. What does this mean? And so this essentially, in other words, what does this mean? For example, if we are to add 7 additional days at the end of treatment, let's do some simple mental math here. So the tumor BED will be reduced by about 6.3 gray. Think about it, because 0.9 multiplied by 7 is 6.3. What that means is that it will reduce the tumor BED from 6 to 7.8 gray to 61.5 gray, which is an overall decrease of about 9%. Now, keep in mind that in this particular stage, our normal BED stays originally as planned. Now, another scenario, instead of adding an entire week at the end of treatment, we could opt to treat, from Saturday to Wednesday. If we, instead of adding an additional week from Monday with the weekend off, if we choose to treat throughout the weekend, then we will only be adding 5 days to the end of treatment. Now, if we add 5 days to the end of treatment, if you multiply 5 by 0.9, that is about 4.5 gray. Now, 4.5 gray is essentially will indicate a 6.6% reduction in the originally planned tumor BED of 67.8 gray, which isn't as bad as adding 7 days. But then the third scenario that we may want to think about could be, we could decide to go the BID route by treating 2 fractions per day. Remember, if we choose to do 2 fractions per day, we have to keep a minimum of about 6 hours between each fraction, right? Let's say we could do 2 fractions per day on Saturday and on Monday, and 1 on Sunday. What this means is that it will extend our treatment by only 3 days. And if we do the math, 3 multiplied by 0.9 is about 2.7, which indicates that there will be about just a 4% drop in our tumor BED. And so the challenge that we face is, if we try to get the tumor BED back to the original plan, we would end up increasing the normal tissue BED beyond what we had initially planned. Or if we choose to give extra doses of fraction, which in turn will extend treatment time, we can either do this by changing the dose per fraction, which in turn can become problematic, especially if we're dealing with sensitive tissues. Now, because of all the 3 scenarios that I've given, there is a drop in the prescribed tumor BED. What if we try to calculate to increase, the fraction dose? How do we go about that? If we choose to increase the fraction dose, how do we go about that? To do that, remember, the original prescribed BED stays constant. And so the new BED, the tumor BED, the objective in this particular case is for us to maintain the tumor BED. And so what that means is that the pre-gap BED plus the post-gap BED minus the tumor repopulation factor will be equal to the prescribed tumor BED, because that is our goal. And we calculated that in our previous slide to be equal to 67.8 gray. If we substitute our values, the only unknown here is D, which is the new fraction dose that we need to calculate to preserve the original BED. And when we calculate the value of D, the new fraction dose is 2.85 gray, would be the new fraction dose. What that means is if we add 5 days to the end of treatment, you will have 5 times 2.5 grays. This is what will be required to restore the original BED. But really, will it be as simple? The question here is, if we increase the original fraction size from 2 gray to 2.85 gray per fraction, are we going to exceed the tolerance of the normal tissues? That is the critical question that we need to answer at this particular junction. And so as the physicist, you need to evaluate whether with this new fraction, are we still going to meet our dose constraints for that particular treatment plan? And to do that, essentially, we need to calculate using the new fraction dose. We need to calculate the normal tissue BED. And if we calculate the normal tissue BED, you realize that the value is 127.8 grays. The originally calculated BED was 116.7, and so the difference here will give us a 9.5% excess in normal tissues. And so the question then that you have to answer is, is this acceptable or is this not acceptable? And this is the point where you have to work with your primary physician to evaluate what this compensated scheme would mean in terms of the equivalent dose in the schedule delivered with 2 gray fractions, as we previously noted. And so if this is considered to be excessive, then it is possible to split the difference. In other words, it is possible to achieve a tumor, biological effective dose of 10, a BED 10, which is a little less than the prescribed dose, while accepting, a slight increase in the normal tissue BED. And so really, at this point, we have to play a trial and error game to be able to gauge what is acceptable or what is not acceptable. And so let's say that if we pick an intermediate dose of 2.8 gray per fraction, then we do the recalculations, we will arrive at 67.42 gray. What does this imply? If we use this to calculate our normal tissue BED, we have about 127.1 gray. And so with about 2.8 gray fractions in the compensation, the tumor and the normal tissue BED are respectively 0.5% lower and 8.9% higher than the unexpected schedule. And so at this point, at this juncture, it is really about us trying to play by we now have a threshold value. We now have to begin to think about what are the compromises that we have to make in terms of maintaining the normal tissue BED and the tumor BED in order to achieve the same outcome. Now, there are a few more important questions that I want to answer here. Does the timing of the interruption matters? Obviously, it therefore matters. If the interruption occurs, within the lag time versus the period of acceleration, within the lag time, we can typically compensate for the gap either using weekend treatments or BID, or if the period occurs within the period of accelerated growth, then we would have to calculate the new fraction size in order to maintain the same local control. Understand that the accelerated repopulation is different for different tumors. In other words, different tumors have different K factors. Head and neck squamous cell carcinomas, you have cancers of the cervix, lung, non-small cell cancers, non-small cell lung cancer, small cell lung cancers, cancer of the esophagus, medulloblastomas, as well as primitive neural ectodermal tumors, as well as anal squamous cell carcinomas, tend to have a K values of approximately about 28 days. And so we really have to think about this carefully. So the next question is, how significant is the position and number of unscheduled interruptions? Now, in this study, which was published way back in 1992, and the study actually looked at the local tumor control in about 971 patients with squamous cell carcinoma of the larynx. They found, now keep in mind that the minimum follow-up period for this particular study was about 3 years. Now, the reason for a gap as documented in these studies was kind of categorized into 4 categories. The gap was independent of the patient, that is national holidays, machine breakdowns. Some gaps were planned gaps for split course radiation therapy. Some gaps were due to severe normal tissue reactions, and some were actually due to recurrent disease. Now, of the 971 patients, only about 12% of the patient had no gap at all. 75%, about 76% had a single gap, and about 2% had more than 4 gaps. And what they found out was that a single gap showed a remarkable trend of increase. The study itself had contradicting results, just to say the least. And so the local control in patients whose gaps began at the 20 to 29 was really indistinguishable from that in patients that had no gap. Now, the study profoundly documented that a gap further towards the end of treatment was also associated with a severe drop in local control that was seen. But the paper itself acknowledged that the mechanism for this phenomenon still remains clear, and that the effect of timing of the treatment gap appears to have a considerable impact on the outcome of radiation therapy. The next question that I want to answer then is, how significant is the position and the number of unscheduled gap? Now, in this study that actually was conducted by Gerard's group in the Boston Oncology Center, they took retrospectively data from about 630 patients from an audit of all new patients that were newly diagnosed with the carcinoma of the larynx between 1986 and 1999. This was a retrospective analysis. And so what they concluded, what they found out was that the endpoints of this study were the local control of the cancer of the larynx in 5 years and the length of the disease-free period as a function of unplanned gaps in radiation therapy. What this study actually came out with, which I actually encourage you to kind of take a look at when you have time, was the fact that the position of the gap of the unscheduled interruption really plays a crucial role, and actually reaffirm our assertion that if the gap is closer to the end of treatment, which in turn corresponds to the rapid repopulation of cells, it has a drastic effect on the rapid repopulation of cells. Now, if you look at this graph, which is still from the study as mentioned, you can see that a gap, if you look at this graph, a gap of 1 day is really potentially damaging, but the greatest effect is at the treatment extension of 3 or more days. And so the gap of 1 day can be potentially damaging depending on what position it falls within the treatment gap that we've already ascertained. But the study actually also indicated that gaps in treatment have a detrimental effect on, the treatment free disease period. Now, a gap has a slightly greater effect than an increase in the prescribed treatment time, and any gap in treatment is potentially damaging. Those were the conclusion. The position of the gap in the schedule was shown in some patients to not be important, but in other patients to be important, which was a little bit more contradictory. Does the length of gap in the treatment matter? When you look at this study, which really was a recent study for head and neck patients with conventional fractionation, the study actually found out that a break of about 1 week is typically associated with an absolute reduction in the local control rate of between 10 to 12%. What that means is that even for head and neck patient, a gap of even 1 day could reduce the local control by a rate of 1.4%, regardless of the fractionation schedule or the primary tumor. I thought this really was a profound conclusion from the table. And so the minimum length of an interruption from this study, which results in the prolongation of treatment time that will have a significant effect on local control, really, according to this study, is difficult to determine. But when we think about it in terms of, standard departmental treatment, we have to keep in mind that even a break in treatment of a day could reduce the local control rate by about 1.4%. And this is a very interesting recent study. Does the type of tumor matters? So this is really an important question. Does the type of tumor matters? One thing is, tumors grow at different rates, and even within the same tumor, the rate of reproduction vary. And when we want to actually quantify tumor growth, we think about tumor growth in terms of the potential doubling time or T part of a tumor, which essentially is defined as the cell doubling time without any loss, as well as you need to think about the net growth rate, or the VBD, of tumors, which is defined as the time required for the tumor to double in its volume. And when you look at this in simple algebraic terms, the potential doubling time of a tumor is defined by this equation. And GF here represents the growth factor. Now, the cell loss factor, which I've talked about pretty extensively, is equal to 1 minus T pod divided by the volume doubling time. And so with this in mind, patients can actually be categorized based on their volume doubling time. And so a smaller VBD here implies a higher repopulation factor. If to keep that in mind. Now, with that being said, according to the Royal College of Radiologists in the UK, there are 3 categories. Patients can be categorized into 3 groups. You have category 1, which are fast-growing tumors, typically patients with low VBD. Category 2, which are slower-growing tumors with intermediate VBDs. And category 3, patients which can be treated palliatively. And when we look at, for category 1, tumors, in other words, tumors which are fast growing, data show very strong evidence that if we prolong the overall treatment time, the local control drastically diminishes for this set of tumor cells. The most famous tumors with very low VBD is famously, the squamous cell carcinoma of the head and neck. You have non-small cell lung cancer. You have squamous cell carcinoma of the cervix, small cell lung cancer. You have squamous carcinoma of the esophagus, the skin, the vagina, the vulvas. You have the squamous cell carcinoma of the anus, the adenocarcinoma of esophagus, and so on and so forth. And so when we are treating patients with category 1 diseases, we have to be extra cautious and be extra very careful when the patient misses or there's a prolonged treatment. We have to make sure that we compensate for the repopulation that occurs in order to keep our isoeffectivity as originally prescribed. For category 2 tumors, slower growing tumors, in other words, in this, if we look back on the study by Bessie and his research group that actually looked at post-operative radiation therapy for breast cancer patients, they retrospectively analyzed the effect of unplanned interruptions in about 900 patients with stage 1 to stage 3 breast cancer, either with mastectomy or breast conserving surgery. Now, of their about 853 patients, 84% did receive adjuvant chemotherapy or hormonal therapy, and patients who experienced interruptions of 8 days had a significantly lower local regional control with an overall lower survival compared with patients without any interruptions of 1 week or more. And so they concluded that a gap of about 1 week for such cases also was an independent prognostic factor, and they actually used a multivariate analysis, producing an average decrease of about 5% in the 5-year local control rate. Just to piggyback here, which once we categorize, when we think about another cancer that is really slower growing are prostate patients, and in this particular case, the overall local control decreases drastically if the gap occurs beyond 9 weeks or more, as opposed to fast-growing tumors if the gap occurs sooner than later. And so the last section of this presentation would be what are the steps to compensate and how do we implement this in the clinic? There are 2 ways we can kind of look at this. In the management of unplanned treatment interruptions, we have preventive measures, and we have compensatory measures. How can we avoid, interruptions, or what are the protocols or the things we can do to prevent interruptions from happening, and what can we do to minimize the effects if a gap do occurs. Now, the preventative measures that could be taken, one, we have to think about this in terms of the causes or the various categories of the gaps, the unplanned gaps that occurs during radiation therapy. Ideally, if everything was equal, every radiation oncology center should have sufficient resources compatible with the departmental workload to allow a percentage of patients to be transferred to an alternative match machine should an interruption occurs. This would imply that every radiation center should have at least 2 match machines, and this is not physically possible, especially in so many different centers across the world. And so so when this is the case, then we need to think carefully about the protocols and to foster a good relationship with the vendors and the service engineers to ensure that there is no machine breakdown, because machine breakdowns can actually cause a severe disruption, and also the time it takes for the machine to be back up running really varies depending upon the accessibility and the availability of finances as well as service engineers. And therefore, the provision of adequate resources in terms of machines, staff, training must be a subject of long-term plannings when it comes to by the leadership of the various centers. Now, patient transport really must be organized to ensure continuity of treatment, because one of the biggest reasons, even here in Michigan, that patients miss treatment is not the unavailability of machines, it's just simply mishap in patient transportation. And so in order to prevent this from happening, nurses, the department needs to think way ahead of time to provide adequate resources for patients to be transported continually to ensure continuity of treatment. And also, patient education is vitally important. With this information that you received today, understanding what happens to a tumor from the start of treatment to the onset of repopulation to the end of treatment, it is important that our patient be aware of the importance of daily attendance for treatment. And this should be clearly stated and signed by the patient, at least to ascertain the importance or the gravity of the situation. And so patient education really is very vital, and that's something that is really missing across radiation therapy centers. Now, there is a big push of medical physics 3.0, where patients are required or encouraged to have a consultation with a physicist, where a physicist can walk them through about their treatment plans and be able to answer questions like these that are very vital for the overall treatment of the patient. Now, the compensatory measures is one, the ideal procedure for mistreatment due to machine breakdown essentially is to transfer all patients to a match machine on the day of interruption. Now, where possible, patients who have missed scheduled weekly treatment should be treated on the weekend. Otherwise, the patients can be treated twice daily with a minimum of 6 hours between treatments. Now, when the first 2 points are not possible, then, like I demonstrated before, we could use the biological equivalent dose calculations to derive an alternative fractionation schedule with involving a modified number of treatment fractions with which to complete the radiation therapy course in the planned time while maintaining the same local control. Now, this table here summarizes the recommendations based on how the interruption occurs. We could either retain the overall treatment time and the dose per fraction by treating on the weekends unnecessary. Now, the benefit of this approach is that the overall treatment time, the fraction size, the interfraction interval, and the therapeutic index is maintained. But the challenge that we face is the fact that we have to work over weekends. There is increased cost because the therapists need to be paid overtime. And this may not be appropriate depending on where the gap occurs at the point of treatment. Another approach would be to retain the overall treatment time and the dose per fraction, and we treat twice daily. The first was adding weekends. Now we're treating twice daily. Now the benefit is the overall time and fraction size stays the same. But the challenge and the difficulty is, remember, we need to keep a minimum of 6 to 8 hours of the interfraction intervals in order to ensure full repair of the normal tissues. And therefore, there is always a potential loss of late normal tissue tolerance. Now, the third option really would be to retain the overall time by increasing the dose per fraction for the same number of post-gap days as they are. In this particular case, we need to employ the calculations as demonstrated before. The benefit of doing this is that the overall time is retained, but still, the difficulty here really is the therapeutic index, like I demonstrated before, will be affected. The only question is by how much, or how much compromise do we have to give in order to attain this. Now, the next alternative for 2B will be to retain the overall time by using a smaller number of larger fractions. In other words, you go the hypofractionation route. And the challenges is still, like I said before. And the last but not the least, we could accept the treatment extension is unavoidable, deliver extra fractions, but in order for us to account for the added number of cells due to repopulation, we need to deliver extra fractions using a higher dose per fraction to minimize, to actually, sterilize those extra cells that are created. Now, the challenge with this is the therapeutic index will be affected. The only question is, what compromise are we going to give? This is the point where the physicist works with the oncologist to decide on the right compromise within the scenario. And this comes to the end of my presentation. Thank you, everybody, for your patience. If you have any questions, please, we can talk about the questions.
Yeah, thank you. Thank you very much for that good talk, Honor. We're probably out of time. However, a number of people have asked me for the slides, and I told all of them to just send me an email. And yes, when you send it to me, I will pass it on to them.
Awesome.
Is that possible?
Yes, yes, that's totally possible.
Great. Cool. But yeah, no, thank you again. I'll go on.
So I have a doubt in how to calculate